Thank you, Professor Hunt, Professor Fitzmaurice. Good morning, everyone. My name is Ronwyn Cartwright, and I have the pleasure of speaking to you today about thromboembolic disease in pregnancy. I've had the privilege of working with some of the leading opinions in thrombosis in pregnancy at St. Thomas's Hospital, and I'd like to talk to you today about just providing you with a general overview and then looking more specifically at the risk factors associated with thrombosis in pregnancy. So the first description of venous thrombosis in pregnancy dates back to 1718, and it was described by a man, a prominent French biologist called François Mariceau, and he described milk leg. And this term was coined because he thought that perhaps milk had metastasized to the extremities, leading to the swollen white appearance of a limb in pregnancy. So what is thromboembolic disease? Well, it's well recognized that a thrombosis is comprised of red cells and fibrin, and this originates in an area of sluggish blood flow, usually in the extremities. In the absence of blood thinners or anti-thrombotic treatment, this blood clot will propagate proximally up the limb, and if it breaks off, a small piece of the clot may travel further up the vasculature, and there's the risk of embolization. The well-known recognized signs and symptoms of a deep vein thrombosis, although not all of these are present, and in fact, a large proportion of DVTs go unrecognized clinically and therefore undiagnosed. But some of the more common signs and symptoms include leg pain, swelling, warmth and discoloration, and depending on where the clot is, sometimes lower abdominal pain or back pain, and a low-grade fever. Signs and symptoms of pulmonary embolus, which you may be aware of, include chest pain and shortness of breath. There may be hemoptysis or coughing up blood, a fast racing pulse, a raised jugular pressure on examination, and perhaps some chest signs when you listen to the chest. Now, venous thrombosis in pregnancy acts slightly different. So there's a 70% of VTEs arise in the proximal iliac and femoral veins, and this is compared to 9% outside of pregnancy. And 90% of DVTs in pregnancy occur in the left leg, and this is compared to 55% outside of pregnancy. And the probable reasons for this is because we have a large growing uterus compressing on the iliac vessels, over there, and also probably due to compression of the iliac artery over the iliac vessel. Now, at the beginning of the 20th century, venous thrombosis was described in 8 out of 1,000 women who had given birth, and a third of these cases were fatal. Now, over the following century, advances in medical management, our awareness of venous thrombosis, and risk assessment and venous thromboprophylaxis has led to a 4-fold reduction in the incidence of VTE in pregnancy, where we now see it's 1 to 2 per 1,000 pregnancies. But unfortunately, this still equates to one fatality every 100,000 births, which is quite significant and largely preventable. Our current understanding of thrombosis in pregnancy is largely due to the maternal mortality data collected on a 3-year rolling basis, and the most recent report was in December 2014. EMBRACE stands for Mothers and Babies Reducing Risk Through Audit and Confidential Inquiry Across the UK. And this is a maternal, newborn and infant clinical outcome program which allows the confidential inquiry into maternal death. And essentially this data generated is a very valuable tool to understand what our shortfallings are in terms of treatment and prevention of venous thrombosis in pregnancy. This slide shows the maternal death rate from 2003 to 2012 is at 10 to is 10 maternal mortalities out of 100,000. And the dot and broken line at the bottom are indirect and direct maternal death rates. Now, direct maternal death rates are defined as direct causes related directly to the pregnancy. So these include urogenital sepsis, thrombosis, amniotic air embolism, hemorrhage, and early pregnancy-related deaths. Indirect causes would be other medical problems, for example, neurological or cardiac medical comorbidities, as well as psychiatric comorbidities. This slide, and it's a little bit small to see, but this slide really, can you still hear me? This slide looks at all direct causes of maternal mortality, and over here, in 2009 to 2011, we can see that all direct causes, there's 82 maternal deaths, and that's down from 107, which is an improvement since the previous period of 2006. If we look at specifically thrombosis and thromboembolus, we see that in 2003, a jump from 2003 to 2008, there were 41 cases of thrombosis-related mortality, which is significantly and statistically significantly improved, down to 18 cases. And that improvement was thought to be due to the publication of the Royal College of Obstetrician and Gynecologists recommendations regarding thromboprophylaxis. Unfortunately, there is now again a rise in the 2009 to 2011 data, and the exact causes for that are unknown at present, but that data will be part of the review that will be published shortly at the end of 2015. Now, possible causes for that increase are probably because of difficulty in implementation of venous thromboprophylaxis. So it's very good that we identify these women, but at the end of the day, they need to get their heparin, and we need to be preventing the VTEs through implementation. So it might reflect that. It might also reflect a change in socio-economic data in the patients. This slide details the causes of maternal death according to direct and indirect causes, and you will see that thrombosis is still the leading cause of direct maternal death. Now, the distribution of VTE in pregnancy and the puerperium is quite interesting. So the risk of venous thromboembolus spans all 3 trimesters. There's a bimodal distribution in the first and third trimester. The risk increases exponentially antenatally to the postpartum period, where it peaks in the postpartum period. 10% of venous thromboembolus occur in the first trimester, and there's 50% distribution between the antepartum and postpartum periods. Antepartum risk of venous thrombosis is increased 5-fold relative risk compared to baseline of a non-pregnant state, and your relative risk can increase 60-fold in the postpartum period. So it's really, from this slide, you can see that whilst there is a significant risk of VTE in the first trimester, and then again through to the third trimester, there's a substantial risk in the first 6 weeks postpartum. So the risk factors for venous thromboembolus in pregnancy. Why are pregnant women more at risk of venous thrombosis? So this is Rudolf Virchow, and today is actually his birthday, and thus we are here to celebrate with World Thrombosis Day. Now, he was a prominent German pathologist who's considered to be the forefather of pathology, and he described Virchow's triad, which describes the 3 contributory factors to thrombosis formation. And this is the altered blood flow through the alteration of normal blood flow or blood stasis, trauma to the vasculature, and an alteration in the constitution of blood, so hypercoagulability or sticky blood. In pregnancy, there's a 50% reduction in blood flow to the lower limbs at 29 weeks, or by 29 weeks. There is also an increased level of factor VIII, fibrinogen, reduced levels of protein S, and a resistance to activated protein C, and decreased fibrinolysis in pregnancy. And what that really means in lay terms is that generally pregnant women have stickier blood. Then there is also the risk of blood vessel damage during delivery, either assisted delivery or abdominal delivery. Now, the risk factors for pregnancy are further increased by risk factors related to maternal risk factors and risk factors related specifically to the pregnancy. So this is a table in the Royal College of Obstetrician and Gynecologists' most recent guidelines. And you can see that maternal risk factors are things that pertain specifically to the mother. So, for example, age over 35 or obesity. And obstetric risk factors would include things specific to pregnancy. For example, perhaps hyperemesis gravidarum or mode of delivery being caesarean section. So I'll speak a little bit about maternal risk factors and go into a little bit more detail in each one of these. So, a previous history of a blood clot. Pregnancy in general increases the risk of recurrent blood clots by 3 to 4-fold. In a quarter of pregnancy-related thromboses, these are recurrent events. Now, some previous VTEs or thromboses have more of a risk factor in terms of recurrence than others. So if you've had an unprovoked or hormone-related clot, this would be a higher risk factor than, say, a clot which occurred after major trauma or orthopedic surgery, and that risk factor is no longer present. But I think what this slide really needs to drive home is that when a woman has a clot, we need to be counseling her that years down the line, she is going to require venous thromboprophylaxis throughout pregnancy. And unless the woman has this expectation, a number of people are going to be missed, no matter how solid our guidelines are. And it's really about educating women who've had previous clots that this will be important when they fall pregnant. Thrombophilia is a risk factor according to the Royal College of Obstetricians and Gynecologists. And although in the non-pregnant population, thrombophilia, acquired inherited thrombophilia, can be considered a relatively low risk factor for thrombosis, in the pregnant population, this is increased. And up to 50% of thromboses in pregnant women, they've been found to have one or other thrombophilia. Now, the most common thrombophilia associated with pregnancy is that of antiphospholipid syndrome. Now, antiphospholipid syndrome is the clinical manifestation of either arterial or venous thrombosis or recurrent pregnancy loss with the persistence of sticky blood antibodies, so a persistence of anticardiolipin or antiphospholipid antibodies. And the most common manifestation of antiphospholipid syndrome is that of thrombosis. The rising incidence of obesity worldwide has certainly affected our general population, and this is no different to the pregnant population. So obesity has been found to be a significant risk factor in the development of venous thrombosis. Obesity increases your risk of thrombosis because it decreases the breakdown of clot or fibrinolysis. It increases venous stasis. In a confidential review in 2006 to 2008, 18 women died of VTE or thrombosis, and obesity was the most important risk factor. So 14 women of those 18 were overweight with a BMI over 25. And normal BMI is 18 to 24.9. But they weren't only overweight. 11 were clinically obese with a BMI of over 30, and 3 of those women had a BMI of over 40. And as I said previously, obesity is on the rise. So in 1993, 1% of women of reproductive age between the ages of 25 to 34 had BMIs of greater than 40, and 14 years later, in 2007, that has subsequently risen to 2.2%. So it's quickly becoming a problem. Maternal age and parity, or the number of babies that the mother is carrying, is considered a significant risk factor for the development of thromboembolus. So we know that the risk of VTE increases with age in both men and women. A woman of 25 would have a baseline risk of 50 out of 100,000 per year, and when she as her age doubles, so does her risk, more than double, and at the age of 50, her risk of VTE is in the region of 123 per 100,000. This pertains also to pregnant women, and the increased risk of VTE is seen in pregnant women over the age of 35 and older. Multiple births are found to be a significant risk factor, in that 47% of VTE related to pregnancy is associated with a multiple birth. Now, looking at pregnancy-related risk factors, we'll look at preconception issues, as well as the pregnancy itself, the modes of delivery and complications. Now, with regards to preconception, IVF and hormone stimulation is known to be an increased risk of thrombosis. In a large Swedish study, there was a 0.2% increased incidence of VTE related to IVF compared to the non-IVF pregnancies, and this was a 10-fold increase. When women have ovarian hyperstimulation, that risk goes up 100-fold. The mode of delivery is also a substantial consideration when assessing risk. So an emergency cesarean carries 4 times the risk of a normal vaginal delivery with regards to the risk of VTE, and twice that of an emergency of an elective cesarean section. So what can we do to prevent VTE in pregnancy? Well, we have mechanical thromboprophylaxis, and this picture is intermittent pneumatic compression devices, which are mostly used post-surgically. And then we have access to anti-embolic stockings. There is very little evidence in the pregnant population about the efficacy of anti-embolic stockings in pregnancy, but we have been able to extrapolate the validity of this in pregnancy from the post-surgical and non-pregnant population. The guidelines stipulate that the use of properly applied, and I think that's key, properly applied anti-embolic stockings is recommended in pregnancy for women who have a contraindication to heparin, or if there are post-cesarean section, if they have more than 4 risk factors, and if they are traveling for more than 4 hours. It's worthwhile noting, however, that there are a few small studies that show that there's a decrease in the lumen of the common femoral and superficial femoral vein in pregnancy due to anti-embolic stockings, and this is therefore probably the reason why they can prevent VTE in this population. we more frequently rely on pharmacological thromboprophylaxis, and the gold standard or treatment of choice is low molecular weight heparin. This is an injectable heparin. It doesn't cross the placenta, and it's not secreted in breast milk, so it's safe to breastfeed. There is a relatively lack of good randomized controlled trials in pregnancy, but this slide describes a large systemic review of the safety and efficacy of low molecular weight heparin in pregnancy. And if we look at how well it's preventing thrombosis, where's my point gone? Sorry. The rate of VTE, it looked at a number of studies, and the total number was 2,777. The total rate of recurrent VTE was in the region of 0.86%, and arterial thrombosis was 14%, which gives you a cumulative recurrence rate of acute VTE of 1.37%. Injectable thromboprophylaxis is not all that convenient to take. Some women need to take it for the duration of pregnancy and twice a day. And there's considerations with regards to regional anesthesia. So I'm just going to go quickly through the management approach and risk assessment according to the Royal College guidelines. We don't really have time to concentrate on all of these criteria, and feel free to ask questions later. So the Royal College of Obstetricians and Gynecologists has provided us with guidelines, but it's worthwhile noting that these are largely based on clinical opinion and are not necessarily validated. This is the risk stratification and risk assessment that you'll find in the front of most maternity books, and it basically risk assesses in the antenatal period and in the postnatal period, and categorizes women into high, intermediate, and low risk for antenatal and postnatal prophylaxis. This slide essentially highlights that maternal pulmonary emboli and fatal maternal pulmonary emboli were in a large proportion in the first trimester and then continued for the six weeks postpartum. And so women need to continue receiving low molecular weight heparin antelatally, and the advice is to continue for 6 weeks postpartum. So our management approach in pregnant women is that of a multidisciplinary approach. We need to identify those high-risk women. We refer them to an obstetric hematology clinic, and key is to review and reassess at points of hospital admission or change in their clinical situation. I'm just going to quickly go through the diagnosis of DVT, which is done on duplex ultrasound. Diagnosis of PE in pregnancy certainly can be performed or achieved through a VQ scan. And that's just a picture of an abnormal VQ scan with some perfusion defects over there and there. Treatment and prophylaxis of low molecular weight heparin is well outlined in the guidelines. And monitoring is not necessary unless in extremes of weight, renal impairment, or recurrent thrombosis. So I'd like to just end off by telling you a little bit about the DIAPEP study, which is a study that is currently recruiting and is run in 8 centres across the UK. So hopefully this talk will have highlighted the importance of pulmonary embolus in pregnancy. But unfortunately, our clinical predictors and blood investigations are not necessarily validated in pregnancy. The scanning techniques are not without some risk to the mother and fetus, and therefore 150 patients are going to be recruited who've had a PE compared to 250 patients as controls, and this will hopefully allow us to draw conclusions about our current predictive clinical markers and perhaps draw up new clinical predictive markers in the pregnant population. So I'd like to just thank my colleagues for their contribution to this talk, and I'd welcome any questions.